Morning. Great to see all of you bright and early this morning. And before we begin, I wanted to take a moment to thank James Thornton and the folks from BNY Mellon Wealth Management for continuing to sponsor this series for us. Also, this series is co-funded, so to speak, by the Friends of Concordia program, and we are pleased to begin another series for you this morning. So, welcome once again. Today, Ed Dinan, good friend of the college over the many years, and incidentally, Ed and Lawrence Hospital was instrumental in helping us think through and bring to fruition the nursing program that has been so successful for Concordia College over the last few years, and for that friendship and that collaboration, we are thankful. Ed will speak from his perspective as president of Bronxville's leading healthcare provider about the challenges of reforming healthcare. He has managed Lawrence Hospital's center for 11 years. Under his leadership, Lawrence has grown with the addition of new services and programs, as well as expansion and renovation of the maternity and emergency departments, with plans to build a new cancer center. Ed came to Bronxville with a wealth of experience of managing healthcare systems in Delaware, West Virginia, and Maryland, including a decade at Cumberland, Maryland, where he was president and CEO of Western Maryland Health System from 1996 to 2000. He's a fellow of the American College of Healthcare Execs, a director of Northern Metropolitan Hospital Association, and a state rep at the American Hospital Association, and also a member of the Chairman's Council of the Voluntary Hospitals of America. A native of Finger Lakes region of New York, Ed holds his MBA from Cornell and a BS in biology from Hobart. I hear that he's a keen sailor, and he and his wife make their home in Stamford and have 4 children. Without much ado, Ed.
Well, thank you, VG, and thank you all. It is certainly my pleasure to be here this morning, and when VG said I was the head of Bronxville's leading healthcare institution, I thought that was pretty good, since it's the only one.
I say the same thing about being the president of college. Leading college in Bronxville.
That's right. That's right. And we're proud of it. And I would add that VG and his wife were among the first to welcome my wife and I to Bronxville. We had a dinner at Paul's house, and is this on? Am I okay with this? Good. All right. And I certainly appreciate that, and it's a fond memory. I appreciate this opportunity to speak with you this morning and to share my thoughts about healthcare reform and the potential impact on Lawrence Hospital. It's an extremely complex subject, and one that sometimes those of us who are in it every day don't completely understand. And not only because of the comprehensive nature of the changes and the impact on the state, the federal, and the local government, but also because of the myriad of consequences, both intended and otherwise, that this healthcare reform is going to have on our country. Someone described the Patient Protection and Affordable Care Act, which is the Obamacare, as similar to an iceberg. It's the part that's not visible that has the greatest potential to cause harm. What I plan to do this morning is to give you a brief overview. I want to define a few terms because what I've found over the years is that while everybody accesses health care, and you can identify an emergency room and you can identify a nurse and you can identify a doctor and you know what surgery is, most people don't have the same level of understanding of health care. So I want to define a few terms. I want to explain the general environment that we work in. I'll give you a few statistics, and that'll establish me as an expert. And then I'll talk about Medicare, I'll talk about Medicaid, and the commercial insurance industry, just so that we can define those three. I'll try to explain a little bit about the Patient Protection and Affordable Care Act that was passed in March of 2010. And we'll talk about today, 1 year later. And then finally, we'll talk about what it means for Lawrence and you. And then since this is an institution of higher learning, we'll have a test. But first, I want to tell you a story. A woman brought a very limp duck into a veterinary surgeon. And the vet looked at the duck and after a few moments shook his head. Said, "I'm sorry, but your duck has passed away." And the distressed woman said, "Are you sure?" And the veterinarian said, "Yes, I'm sure. The duck is dead." But isn't there something more you can do? How can you be so sure? So the vet rolled his eyes, and he turned around and he left the room. And he came back with a black lab. And the black lab came up and put his paws on the table and sniffed the duck from head to toe. Looked at the vet, shook his head. And a few minutes later, the vet came back in again, this time with a cat. The cat jumped up on the table, sniffed the duck from head to toe, looked at the vet, meowed a little bit, shook his head. And the vet said, "I'm sorry, but as I said, it's definitely 100% certifiably dead." And the vet turned around and went back to his computer and punched in a few keys and handed the woman a bill for $150. And outraged, the woman said, $150 just to tell me my duck is dead? And the vet said, "Well, had you taken my word for it, before I had the lab results and the CAT scan, it would have only been $20. Well, that sort of sometimes is what healthcare is like. Just another quick aside, I had dinner Saturday night with a neighbor of mine whose dog was attacked by two pit bulls. And he said the poor owner of the dog was, the two pit bulls was, very remorseful and said, "I'll pay for everything." And I asked him, I said, "Well, so far, what's the bill?" He said, $15,000 cash. I'm not sure that any of our surgeons get paid $15,000 for anything that we do. Anyway, Medicare. Medicare, the hot topic of the moment, it's a federal program that's for those over 65. It was instituted in 1965, and it's administered by the federal government. There's traditional Medicare, which many of you know. There's Medicare Advantage, which is a managed care plan. And then you've heard of Medicare supplemental plans. Remember Lauren Green when he used to sell them on television? For that part of the insurance on your insurance. Medicaid is a shared program between the states and the federal government for low-income poor. It's a 2-to-1 match. For every dollar that the state puts in, the federal government puts in $2. Remember that. The the coverage and the reimbursement by state. It's different in New York than it is in Connecticut than it is in New Jersey. It pays for most of the nursing home care. Most patients in nursing homes are covered by Medicaid. Medicare gives you about 120 days. After 120 days, you flip to either self-pay or Medicaid. New York State has the highest per capita cost for Medicaid of any state in the country. Number 2 is 5 times less. 19% of the population in New York State is Medicaid eligible versus a 13% average. So you have Medicare, you have Medicaid, and then most of us in this room have commercial insurance. It's an employer-based, employer-sponsored plan. Empire, Oxford, United, those are all examples. There's usually a deductible, usually a copay that goes along with it. And the New York State managed care companies are some among those that operate in the state are among some of the most profitable in the country. When you hear the term self-pay, that means that usually people do not have insurance. CMS is the Center for Medicare and Medicaid Services. You'll hear a lot about CMS, or the Secretary of CMS. HHS stands for Health and Human Services. Some key numbers. McKinsey reports that $2.3 trillion was the total U.S. spending in 2008. It's 17% of the GDP. 1 out of 9 people work in healthcare. Between 1970 and 2006, healthcare spending grew at 4 times the rate of inflation. There are currently 51 million uninsured Americans. And for 2011, the average employer-based premium will increase 11%, and the average family plan is expected to cost $13,000. Jobs in healthcare added 1.7 million jobs between 2001 and 2007. And in 2007, that was 45% of the private sector growth. A big economic engine. So when I talk about the unintended consequences, you've got almost 20% of the economy affected by what happens with this healthcare bill. The most frequently billed diagnosis, sometimes you'll hear DRGs, diagnostic related groups. For Medicare are heart failure, pneumonia, major joint replacements, psychosis, chronic obstructive pulmonary disease, are the most frequently billed diagnoses that we see at the hospital. Physicians, their salaries have gone down every year for the past 7 or 8 years. And you may have heard about, but it's unlikely, the doctor fix. Every year for the past, I think it's 5 or 6, Congress has had to pass a bill stopping, or funding, I should say, a 20% cut to physicians' reimbursement for Medicare patients. So that if they don't, they funded it till December. If they don't fund it again at December, doctors will get a 20% cut. According to the 2010 census, there are about 307 million people in the United States. The numbers that I look don't quite add up to that, which is, or actually add up to more than that. So it gives you a little bit of indication that the numbers surrounding healthcare are not 100% accurate. There are 170 million who are involved of us who are involved in employer-based plans. Those that purchase directly from a third party, they're about 27 million. Medicaid and Medicare are roughly equal, around 45 million. The military is another 12 million. And the uninsured, as I said, is about 50 million. Our per capita spending ranks number 1 in developed countries. However, our health ranking is number 6 or 7. We have a healthcare system that is reflective of our national values. It's highly independent. It's entrepreneurial. It's suspicious of centralization. And it's highly regulated. You know, we talk about expectations in healthcare. We had a conversation earlier about healthcare in England. People say, well, why don't we do the Canadian system or the English system or the German system? We couldn't tolerate it. We are used to what I refer to as drop-of-the-hat medicine. The most frequent call I get, Ed, I'm coming to the ER. Can we get through? I don't want to wait. You come to my ER, the biggest fear you have is you're going to be there for 4 hours. You know, my daughter, Sunday night, sliced her finger down in D.C. She avoided going to the ER. And her first question was not, what do you think I should do, Dad? It was, how long do you think I'm going to wait? It's highly individualistic, and we want what we want. There are very few effective controls on how doctors and patients choose what we get. Hip replacements are a good example. There are hips that cost X, and there are hips that cost Y, and there are hips that cost 2Y. It doesn't matter which one you pick, or your doctor picks, because your insurance company is going to pay for it. There is nothing else in this country that we buy where there is no connection between the purchaser and the price. Nothing. So as long as there is that disconnect, there is no downward pressure to hold costs down. Because if there's no consequence to my decision, I'm just going to keep paying for what it costs. There's no choice of whether or not I go to a doctor clinic, which might be cheaper than walking into the emergency room. Definitely is cheaper, because it's going to be paid for. In fact, it's probably going to be paid for if I go to the emergency room more than if I go to the clinic. Economist Amy Finkelstein of MIT estimates that 50% of the real increase in per capita healthcare spending from 1950 to 1990 is reflected simply in the spread of comprehensive insurance, because now I've got this care that's paid for. Think about dental insurance. Most of us grew up without dental insurance. So we didn't go twice a year. We didn't get the x-rays. We didn't get necessarily all the things that our children got, because it's paid for. Now, lots of good came out of that. But the consumer out-of-pocket expense in 1950 for medical care was 50%. Today, it's about 13%. I'm fond of saying that if you don't understand something in healthcare, just follow the money. As I said, Medicare was established in 1965. In 1965, there were 19 million beneficiaries, and life expectancy was 67 years for men and 74 for women. Today, Medicare covers 44 million lives, and life expectancy is 75 for men and 80 for women. It's estimated that by 2015, that 45 million will rise to 53 million as that baby boom bubble goes through the system. And life expectancy will be 76 and 82 respectively. So you see what's occurring. There's this big bubble of demand that is coming through. And most Americans who approach 65 and are eligible for Medicare believe that they're only going to have minor out-of-pocket expenses. And under the current program, to some extent, they're wrong. Because when you stop and analyze it, there's a significant out-of-pocket expense that many of the current Medicare beneficiaries face. We already talked about insurance on the insurance for the copays and the deductibles. According to a study that was done recently by the American Hospital Association, a couple who are both age 65 in 2006 and in living with an average life expectancy would need almost $300,000 to cover their Medicare and Medigap coverages for out-of-pocket services. And if they live to 95, that number jumps almost to $500,000. The growth in the number of beneficiaries and the increase in life expectancy and the per capita use of the system and the rise in healthcare costs present our nation with several challenges. One is how to fund that. The second is, how do you maintain affordability for the seniors as they go through that system? It's not only a financing issue for the government, but it's also a financing issue for individuals. And when you take, in 1967, for example, hospital deductibles were $40. Today, they're close to $1,000. And in this long-range planning study that the American Hospital Association did, they took a look at what Americans were saving. And they found out that there simply wasn't enough money. In addition to the funding of individuals, BDC did a study and said that by 2017, if we do nothing, the Medicare Trust Fund is broken. Individuals that are involved in Medicare have not saved enough money. And if the cost per enrollee, and if Medicare and Medicaid, we haven't even talked about Medicaid yet, continue to grow for the next decade as they have for the last four, those two programs will increase from 5% of the GDP, they're 5% of the 17%, to 20% in total. Peter Orszag said, over the long term, the deficit impact of every other fiscal policy variable is swamped by the impact of healthcare costs. Warren Buffett in March of 2010 said that the U.S. high cost paid by U.S. companies for U.S. healthcare put them at a competitive disadvantage. He called the difference between the U.S. 17% GDP and the rest of the developed world as a tapeworm eating at our economic body. When we talk about the seniors, we also said that they had very little retirement income, which is going to be a significant drain on their retirement plans. So that's the sort of the state of Medicare, where it is, and trying to understand why this issue became such a hot issue in the Washington politics. Let's talk a little bit about Medicaid. Medicaid, again, is the program for the poor, funded $2 for every $1 that is put out by the state. And there's a wide variability in all these 50 states, and every state and counties in New York State, because Westchester County is responsible for a portion of the state Medicaid program, are facing significant challenges with their Medicaid program. As they find that between Medicaid and employee benefits and schools are the big drivers of state budgets. And the federal government is worried about states shrinking their Medicaid programs at a time when the Patient Protection and Affordability Care Act plans on sending more people into the Medicaid program, which shifts the burden back to the states and the local governments. Many people haven't realized that, is that the ACA is expecting to put a significant number of people eligible to enroll in these state Medicaid programs. I talked about the generosity of the New York State program. In this plan, it would force about 16 million of that 51 million into Medicaid programs by 2014. The Texas Medicaid program is expected to grow by at least 65%. How'd you like to be the governor of Texas trying to figure that one out? In Virginia, about 21% of their state budget is currently consumed by Medicaid. It's expected to grow to 28% under the Affordable Care Act. During the first 3 years, the federal government has said, we'll pay 100% of it. But then you know what happens after that. And in addition to that, that 16 million, the law has a penalty that if you do not buy insurance, you're going to have to pay a fine. There are lots of people who are Medicaid eligible even today that won't sign up. And if you're forced with paying a fine or signing up for Medicare, you're going to have more people than the 16 million going into the state Medicaid program. You can understand why the states are upset. Remember I talked about the unintended consequences, the things that are below the iceberg? Recently, as last week, the CMS actuaries who looked at this have determined that the federal share of the Medicaid costs are a lot more than what they initially predicted. Anybody surprised by that? Their estimates put the government's future obligation at $725 billion between 2010 and 2021, an increase from 410. Recently, here in New York, Governor Cuomo put together a task force and said, either you cut it or I'll slash it. And they've agreed on a 4% Medicaid cut. So as a hospital provider, I can expect my Medicaid reimbursement to go down by 4%. Commercial insurance, it's the third leg of the stool. That's what most of us have. And these plans have been a tradition in our country for many years. They cover private sector, they cover public sector. If you watch the debate that's going on in Ohio and in Wisconsin, it's all about health care. Most of us pay a certain portion of the premium. Most employers have an 80-20 split, where the employer will pay 80, you pay 20 of whatever it costs. And most government employers, if you will, have contracts with their unions that very little is paid, very little the cost is shared. Again, a disconnect between what it costs and what you buy. And that's what the debate in Wisconsin and Ohio is all about, because these unions, the government is trying to figure out how to control costs, the unions are trying to figure out how to protect their benefits. Commercial insurances fall into several broad categories. You basically buy a policy like Aetna or Oxford or Empire, and then there's a deductible every time you use it, and then there's usually a copay every time that you go to the doctor. So there's and those plans are usually indemnity, which means that an employer will buy it and insure against the outcome of how much is going to be used. Every year it's going up, and as I said, for 2010 it's expected, or 2011, about 11%. Most large employers, including Lawrence Hospital, self-insure, We use Empire as an example as a third-party administrator. They basically administer the claims for our employees. But Lawrence pays $1. We use their network of providers, we use their contracts, but we pay, as most large employers do, direct dollar for dollar. So I have an incentive as an employer to manage my health care costs. Now, let me give you an example. If you operated, let's say we operated a restaurant under the same rules that hospitals have to operate under, and assume for a moment that everything costs $1, and that every senior citizen who walked through your door, they don't even have to walk in before 5 o'clock, gets a 25% discount. And every low-income provider or customer who walks through the door gets a 35% discount. Now, I know you're all smart people. If you're going to stay in business, what's got to happen to the other people that walk through the door? If everything costs $1, they got to pay more. All right? And that's exactly what happens. Medicare gets a discount. Medicaid gets an even bigger discount off of what it costs us. So what nobody likes to talk about, and I call the hidden tax, is the subsidy that's paid by all of the private employers that subsidizes everybody else in the restaurant. In addition to that, just for good measure, anybody who's hungry and doesn't have a card comes to your restaurant, you got to feed them too. Now you can collect from everybody because some have coupons, some don't have coupons, some have a little extra they got to pay. But you can see the incentive that's set up. It's the way healthcare works. And at Lawrence, we see that all the time. The employers certainly subsidize the government, and they subsidize the state government. What we're seeing is, and you saw this with our recent Blue Cross contract, is that the commercial insurers are saying, you know, we're tired of paying the subsidy because a lot of this is coming directly out of the bottom line of these companies, or they're seeing the 11% premium creep to 15%, 13%, and it's certainly not what we're seeing in terms of the reimbursement, but it's the subsidy to cover the costs. Now, the one thing that everybody can agree on is that the payment system is a mess. And I hope that I've given you a picture of sort of why we are, how we've arrived at where we are. And hospitals, physicians, patients have very few incentives to work together. We're basically a body shop. You come see us when you're broken, and we fix you. Dollars rarely flow to preventive disease prevention, or do we address chronic conditions which consume about 75% of the healthcare dollars? The healthcare debate has been raging for many years, and it's been focused on how do we increase coverage, decrease the cost, and who deals with the social burden of healthcare. And in the United States, we've declared healthcare a right, but we've not declared who's accountable. And that's the essence of the problem. Everybody thinks healthcare is a right. Answer the question, who's accountable? In my mind, that's what's formed the basis of this debate that we're in right now. According to a Commonwealth Fund survey that was released last week, more than 70% of the U.S. residents think that the healthcare system should be reformed. The question of how is where we all differ. Now let's talk a little bit about the Patient Protection and Affordability Care Act, affectionately known as Obamacare, that was passed on March 23rd, 2010. It was a roadmap for healthcare reform for the next decade. Now, in putting this together, this was probably the most difficult part because I had to check, even last night, what's going on. But it was signed into law, and its supporters touted many of the key provisions, which are hard to argue against, ensuring that all Americans have access to affordable care, creation of new regulated marketplace where consumers can purchase affordable care, extending relief to small businesses, improving Medicare by helping seniors with disabilities afford their prescription drugs, the donut hole, remember the donut hole? Prohibiting denials of pre-existing conditions, limiting the out-of-pocket expenses, helping young adults get started by letting them stay on their parents' premiums till they're age 26, expand Medicaid to millions of people so that they can have access to insurance, providing sliding scales so that there are subsidies to make premiums affordable for people, hold those darn insurance companies accountable for how healthcare dollars are spent, and invest in preventive care. Now, it passed, if you recall, through the Senate through a filibuster-proof motion. It took 60 votes of the Senate. It passed 60 to 39, and it passed the House of Representatives by a vote of 219 to 212. Very narrow margin. And remember, it was the Senate version, not the House version, that got passed, and 2 days later, the President signed it into law. And we talked about the Medicare donut hole. That donut hole is that the bill eventually closes the gap, which currently begins after you've spent $2,700 and starts again after you've spent $6,100. There are two main components of this redesigned bill. The first is insurance reform. They want to expand coverage, and there's this individual mandate that everybody have insurance. The other part is delivery reform. So we've got insurance reform, expanding coverage, and individual mandate, and delivery reform, which is in the process of creating new organizational structures. You'll hear about accountable care organization. Those regulations came out last week. You'll hear about medical homes, where people will be required to put together doctors and hospitals so that there'll be a group that is looking over your care in a coordinated, integrated fashion. Sounds good. Not sure how it's going to work yet. And there's also some payment reforms where hospitals and doctors are going to be measured on outcomes. What's the quality look like? Have you met certain metrics? How often do patients that are discharged from your hospital get readmitted someplace else? Since that passage of the Affordable Health Care Act a year ago, the debate has not stopped. In fact, some might say it's even intensified. You name the group, they've been involved in the debate. There's certainly been a lot of discussion around the country from special interest groups. And there are so many moving pieces and so many variables that it's still up in the air. Last year, after the controversial and extremely drawn-out fight, the President and the leaders of the Democratic Congress predicted that the law would gain popularity as different measures have gone into effect. I think it's safe to say that hasn't happened yet. More than half of the states are suing the federal government. And hopefully you can understand why, particularly as they look at the Medicaid impact on their budgets. And after the Republican midterm victories last fall, the first thing that the Republican House did was pass the repeal and replace bill. And now are threatening, as of recently as last weekend's budget battle, and that was for 2010's budget, that they're now starting the battle for 2011 to defund certain provisions of the Patient Protection and Affordable Care Act. So you're seeing that this debate is going to continue to go on. Tea Party, the Tea Party activists, the Tea Party platform rode into power largely on the back of government spending and particularly the Obamacare. And depending upon what poll you look at, what day of the week you look at, what position you tend to favor, it appears the country is pretty evenly divided on this issue, on whether or not to support health care reform. And earlier this year, as I said, the Republicans delivered this repeal and replace bill, which didn't pass the Senate, but it's now becoming very focused on 2012. And I want to talk a little bit about beyond the obvious, which is the Republicans are looking to take control of the Senate and obviously the presidency. But in the meantime, the more likely approach is embarking on the limitation of funding for a lot of these programs. Repealing the bill is not all that straightforward. It would require a rollback of some very popular programs. Those things I talked about earlier are very consumer friendly. And the Democrats have countered that if you can't produce 60 votes in the Senate, which makes it filibuster proof, you're probably not going to get out of the Senate. And of course, if you don't have a Republican president, he's never going to sign the repeal bill. However, some Washington insiders have pointed out that there's a process called reconciliation that requires only a majority vote of 51 in the Senate in order to repeal a bill, provided you have a Republican president who will sign it. And a lot is happening. And as a provider, I'm trying to figure out what direction we're going in, what is allowed to happen outside the bill anyway, what key provisions are going to be there. They've passed these regulations for accountable care organizations. Are they going to be in effect? Are they going to be funded? Are they not going to be funded? And just to top it all off, there have been numerous lawsuits that have been filed. I talked about the 26 states' attorney generals who joined Florida in their lawsuit. And U.S. District Court Judge Robert Vinson a month ago ruled that the individual mandate portion, the portion of healthcare, the healthcare bill that requires people to have insurance, is unconstitutional under the Commerce Clause. Because the government doesn't have the authority, under his logic, to require you to buy something, which is what Obamacare is doing. And I'm not a lawyer, there is a clause that says that because there was no severability clause in the bill, which connected it, therefore, which means that if one part of the bill, you can just carve it out and leave it apart, that the entire bill is unconstitutional. And that requires that you declare the whole thing unconstitutional. The Department of Justice has filed an appeal of that. In Virginia, Judge Hudson also ruled the individual mandate unconstitutional, but didn't rule on the entire bill. It's obviously headed to the Supreme Court. And we're going to see a lot of activity around that as well. It doesn't stop there. Just this week, the Republicans, under Representative Paul Ryan, released their premium support plan and their 2012 platform going forward with the budget, which gives you a picture of what the Republicans are going to advocate as part of this repeal, replace, whether it's declared unconstitutional or whether or not they're going to be able to replace it or repeal it. And this premium support plan looks at Medicare and Medicaid a little differently. Its intent, according to Representative Ryan, is to rationalize Medicare's burden on taxpayers by introducing market competition. It's intended to cut $4 trillion over the next decade, and Medicare would become a federalized subsidy of private insurance, allowing people to buy it on the open market, much like people do today with the Medicare Advantage plans. Medicaid, the other big program for the poor, would shift from that 2-to-1 process to state block grants. Now, as recently as last night, or yesterday's Wall Street Journal, there was a story about the difference between, if you read it, between Mario Cuomo and Chris Christie in New Jersey. Republican, Democrat, but they've both been sort of in lockstep in terms of trying to get their state governments under control, but this is where they differ. Christie's in favor of the block grants. Cuomo is not. And the reason is, it's highly unlikely that the block grants are going to support the level of spending in New York State, which again is 5 times greater than number 2, than New Jersey's plan. So there's an awful lot that is complicated in moving this thing forward. Finally, let me take a stab at what all this means for Lawrence Hospital, other than that my hair is going to probably fall out maybe by the time. It can't go gray. It's already there. Although I tell my kids I'm blonde. Here's the annual report from 1965. And I just want to read 2 things for you. The first one is long-range progress. And the North Wing was being talked about at that time, and they had just finished the new South Wing. And Vijay will appreciate this, the new South Wing of the hospital. Right, that's 5 South, and well, it cost $3 million. Actually, the total cost was $5,234,000. We barely buy a CAT scanner for that today. Our new cancer center, for example, which is a 3-story addition, is projected to cost $35 million. So you add a 0 to this. But let me read this. It says, plans for Medicare are studied. One of the major concerns, 1965, of the Board of Governors, the administrative officers, and members of the medical board is keeping abreast of the great volume of information coming from Washington and other sources relative to Medicare. All hospitals in the nation will experience a far-reaching effects of Medicare, although it is not possible at this time to discern what the effects will be. The details of the provisions are being carefully analyzed at Lawrence to determine their impact on the hospital and its services. Very prophetic, for sure. The majority of the hospitals in New York State are in the red. About 80% of the hospitals in New York State lose money. And it's because of that difference in the subsidy. Because you basically get paid the same for Medicare, you get paid for relatively well for Medicaid. But if you had an appendectomy at Lawrence and you had that same appendectomy at Greenwich or in New Jersey at Valley Hospital, you'd be paid about 25% more, as the hospital would be. We're fortunate in that we make about a 1% margin. And between our pension costs and our supply costs, our labor costs, the cuts that 4% cut and the 2% cut we're going to get from Medicaid or from Medicare, and the ever-increasing burden of bad debt. We're seeing our bad debt go up from 2 sources. People coming to our emergency room who have no insurance and say, yeah, we'll pay you. We don't get paid. And those who come in with high deductibles and copays. People will pay their cell phone bill before they'll pay their hospital bill. The other big change that we've seen is over the last years is the hospitals over the last 2 years has begun employing physicians. All of this has affected hospitals. It's also affected physicians. When you look at Lawrence, we've been fortunate that doctors have wanted to come to this community. Over half of the graduates today in medical school are women. They're smarter. They don't want to work the 80 hours. They want coverage. They want a salary. They want a life. They want benefits. And if you're not prepared to give them that, they'll go someplace that will. So the board, several years ago, realized this. And we looked ahead and said, who are the doctors that are going to be here in 5, 10 years from now? Who's going to replace all the doctors that have been here if the new doctors want to go to work for somebody? And the answer was, we don't know, because nobody was hiring new doctors. You're not seeing the private practice of medicine expand. In fact, my prediction is in 5 years you won't have an independent practice of medicine. No doctors today, 98% of the doctors go to work for somebody. Nobody's going out to set up a shingle. You can't afford it. An OBGYN today, as an example, before they ever set foot in the hospital, has to pay $165,000 for malpractice insurance. You got to deliver a lot of babies to pay for that, especially when your overhead runs 60%. 60%. So we've gotten involved not only in employing existing practices, but also physicians who are interested in coming to the area. You may notice up on 685 White Plains Road, the old, right across from Lord and Taylor's and Borders up there. You'll see Lawrence Medical Associates, the hospitals. We have physicians that are in that office. We expect to double the number of physicians, and we'll probably be around 20, 25 physicians by the end of the year that are employed by the hospital, of varying specialties, mostly primary care, but varying specialties. And the other challenge we have are the changes that the private insurances are placing on the hospital. You know, we were out of contract for 4 months with Blue Cross. It was a battle not only over money, but also their desire to implement controls on readmissions and quality incentives, which sound good, but but they're challenging. For example, they keep track of every readmission to the hospital. Sounds okay, but patients go home. They go to nursing homes. They go God knows where. A lot of them are non-compliant. We have responsibility for these people after they leave the hospital that we can't control and we don't get paid for it. But from Blue Cross's point of view, they're going to keep track of us, as will Medicare in the future, on whether or not they're readmitted. There are many ways to control costs. And as you look over and many people have tried and they've failed. And the reason, I think, principally is it's very complex and there's a lot of politics involved. And there's no major constituency that's controlling spending. As I said, because most patients don't pay their bill, they have little interest in controlling costs. Doctors and hospitals have no current incentives to limit care. In the future, we're going to see a lot more public reporting about doctors. You're going to hear more about pay for performance and value-based purchasing, where insurers and the government are going to tie outcomes to the payment system. You're going to see greater hospital-physician integration than you did before. We'll start to see experiments on bundled payments where hospitals and doctors will be given a lump sum for that appendectomy and have to decide how to divvy it up between the surgeon, the anesthesiologist, and the pathologist and the radiologist and all the other ologists that are out there on the case. You'll see a lot more electronic medical records. Here at Lawrence, we're among the leaders in the country in terms of our use of technology, electronic medical records in the hospital, and we're now in the process of expanding that to our doctor's offices. You're going to see these accountable care organizations where these organizations will start to take risks. They'll become almost mini insurance companies. Commercial insurers, as we've said, are going to be unwilling to accept that burden of subsidizing the governments. Healthcare change is not going away. And even if Obamacare is repealed, I think the train has left the station. You're going to see the commercial insurers driven by their employers who are going to say, I'm not willing to subsidize it any longer. Somebody asked me, said, Ed, what are your thoughts? How would you do it? And I look at it with a simple answer: dental insurance. Dental insurance works. We have a certain amount of preventive care. We all go to the dental insurance. Everybody gets primary care, if you will. X-rays are taken. We want to keep your teeth healthy. And if you misbehave and you've got a cavity, most of it's covered, but you've got to pay something for it. And you've got lifetime benefits for certain things. And then there's a possibility for catastrophic coverage, certainly if you go into have something significant. In the middle, that's where you can buy insurance for certain things. And we all can buy different ones. I think there are enough smart people out there that could figure out how we could cover primary and preventive care. But you're not going to die if you don't get your hip replaced. You might limp a lot, but you can buy insurance. The program is broken. We cannot afford to do what we're doing. And I define the U.S. healthcare system as the best healthcare somebody else's money can buy. Think about it. We don't make that connection. Until we do, we're not going to fix the system. The one criticism I have of all the reform bills is they've done nothing to deal with the insatiable demand that we have. I'm going to stop there because I could keep going for days. This is a very complex subject, and I'll be happy to answer anybody's questions. Thank you very much. Yes.
Yes. How is Lawrence Hospital been affected just in the past year by the bill? I mean, it came into effect, you say, about a year ago. Has there been anything drastic, or is it just kind of waiting to see how it turns out? Has there been a real change in things at Lawrence because of that?
I think there are two things that really have happened this year, all driven by speculation. The first and foremost was the Blue Cross contract, because the Blue Cross contract was last summer, after the bill had passed, and there were lots of provisions in the bill. And I believe that the insurance companies took advantage of that as a way to change. We've seen that continue. So they're riding on the heels of that. So that our normal course of events in negotiating these things have gone on for the 11 years I've been here. It was different this time. That's number one. And the rates of it, that we were negotiated were a lot less than what we've done in the past. And we have about 3% of the increase at risk in divided equally between the readmissions and the quality and patient satisfaction, which are not bad things. It's just different. The second thing, which is the fastest explosion I've ever seen in my life, is the number of physicians that come to my office and say, Ed, let's talk. And I am shocked at how difficult it is for these physicians to make ends meet. Shocked. And after all of the work and effort that they put into to their education, relatively how little money they make. And And again, as a community, when you take a look at this from the community resource, the hospital is only one part of it. You know, we've got to have nurses, we've got to have doctors. And I see that's where the board's perspective and the hospital's perspective is broadening much more beyond just the four walls of the hospital, just trying to keep it open. Well, we've got to take care of the doctors as well. So those are the two things, yes.
A not-for-profit.
Yep.
Servicing low income, no income, Medicare, uninsured,
Mm-hmm.
with clinics around. What do they do? What's the future for them?
I think that they will all continue. There's a huge unmet need out there. And one thing this bill did not address are the undocumenteds. They're still going to show up. It's amazing to me, the people that show up in our ER. You know, we're a victim of our own success because we're now drawing deeper and deeper in the Bronx. When I came here 11 years ago, we had about 25,000 visits in the ER. This year, we'll be close to 40. And that continues to grow. The number of people without insurance that are showing up continues to grow. We try to enroll them in Medicaid because we think they're eligible, but if they're not documented, they're not eligible. A lot of people don't want to participate because they don't want to, you know, they don't have to, number one, to get the care, and they don't have to in order to, they're worried about immigration issues. And we'll service them anyway. So the clinics will still be there. There's still a huge unmet need out there for access, and I think that's important. The not-for-profit doesn't mean you don't make a profit. Not-for-profit means that the profits don't go to any one individual, a stockholder or anybody, an owner. And so and businesses like ours have to reinvest. You know, a CAT scan. We've for example we've had 2 low-dose CAT scans that we've introduced to the hospital in the last year, both of which are the only ones in the area that are, you know, a normal CAT scan is a significant amount of radiation. These are significantly less than that. But both of those were well over $1 million. You got to have money to do that. That's where the money is reinvested back into the hospital. The cancer center that we want to build. An extremely needed project, one that is going to be extremely beneficial to the community because of the desire to have that treatment locally. That's got to be paid for with investments and returns as well as some borrowing. So not-for-profit does have to make a profit, and I think that those, you know, the Patient Protection and Affordability Act does not cover everybody. And again, society hasn't, you know, I'm the first to say that you know, and I've been doing this for over 30 years, I've never seen anybody not treated, and we're required by law to treat people. It's a question of who's going to pay for it. You know, we declared it a right, we didn't declare who was accountable for it. Yes?
Okay. I mean, obviously, your talk was really terrific and very, very informative. So I have to apologize for making the remark that I'm going to make because I really don't mean it as anything against what you're saying. But yeah, I would like to say that obviously when someone's sick, they want the best medical care. I mean, there's no doubt about it, and probably people go to the most expensive doctor they can because they want the best. The more expensive it is, the better care it is.
Well, I just
Okay. On the other hand, it's a little something's wrong with our system when we're worrying about the cost of Medicare going up, and originally the tax on high-income earners was like 90%, and now it's down to 35%. And Congress last year was against Obama raising the tax on high-income earners 2%. For God's sake, somebody, and this, the Wall Street Journal mentioned, had a list of the CEOs and their salaries where some of them are making $84 million a year. So this, I mean, for God's sake, there's something wrong with our system where we're worried about the increase of Medicare costs, and on the other hand, there's people who are making these obscene salaries and incomes, and they're fighting to keep their taxes down. So if the taxes went up on some of the people that have way more money than they can ever spend in their lifetime, maybe we wouldn't be worrying so much about the increase in Medicare taxes.
I think, you know, and I don't disagree, but I think they're two separate problems. You could tax every high-paid CEO another 2%, still wouldn't solve the problem. It's a drop in the bucket. The problem, in my estimation, is that we haven't solved the fundamental problem. And we see it on the provider side, where there is absolutely zero incentive for people to figure out, to make choices. The choices you make every day. Am I going to eat at this restaurant? Am I going to eat at that restaurant? Am I going to buy premium gas? Am I going to buy regular gas? Am I going to drive a big car? Am I going to drive a little car? All those issues. And to be very honest with you, most of healthcare doesn't need the most expensive, doesn't need the most sophisticated care. Most of it is bread and butter medicine. There's no personal accountability for whether or not I'm 25 pounds overweight or not. You know, we didn't even talk about obesity. I could talk about that for days in terms of the impact it has on healthcare costs. I think that my response would be there are two separate problems, and we've got to not only, everybody should have access to healthcare. There's absolutely no question in my mind. The way we do it is fundamentally flawed.
Yes. Are we pushing back preventative medicine in the U.S. compared to, should we be more straightforward and forwarding preventative medicine? Because it seems the way that you were saying it today, that we're not looking forward as far as doing more preventative medicine as opposed to just curing people that come in sick. Because it seems it's more cost effective to be on the side of preventative.
Yeah, and I think the answer to that is absolutely yes. But right now, nobody pays for it. All right? So what incentive when you go to your doctor, other than he'll sit down and he'll say to you, geez, I think you ought to go lose some weight and go to the gym, and your cholesterol's a little high, and you maybe you ought to think about, they'll have that conversation with you. But if you're a diabetic patient or a congestive heart failure patient, studies have proven that if you watch the weight and the fluid content, or you're managing your insulin, you can take better care of yourself. And nobody is paying for that. It's going to cost, and so the payment system has to be restructured. And that's what these accountable care organizations are attempting to do, is to put, a bolus of money, and it's basically managed care or capitation. You heard that word, it was a dirty word before, but it's what we're headed to, where there's a group of people that are going to say, Ed, we're going to pay this group, $25 per member per month, and you're going to take care of all those healthcare costs. So now that group has got an incentive to help me quit smoking, lose weight, drive safely, use my, all the things that we should be doing. And it's, the way the system works right now, there's no incentive for that to happen. Yes?
Do you see any business opportunities now or in the future to promote wellness programs and participation in preventative medicine so that we could offload some of the burden on the healthcare system? And along with that, are there any government programs funding such wellness and prevention programs?
The answer to the last question is not that I'm aware of. There is opportunity. It's been around for a while. But you've got to figure out, as an employer, why am I going to invest X amount of dollars to try to get my, to get people into this program if there's no consequence to the behavior. I've run wellness programs before, and the people who are going to participate already would have participated anyway. We've got to figure out a way to change people's behavior. Yes?
On the doctor's liability insurance, do you feel that that is a problem that needs to be addressed? And if so, what kind of percentage impact would it have if you cut down on that expense?
The answer, yes, I believe it needs to be addressed. It was supposed to be, it was part of this Medicaid package in Albany, part of this budget, to put a $250,000 cap on pain and suffering. It did not pass. Trial lawyers had a significant lobby. In states that have enacted the cap, have seen their malpractice premiums drop, and their physicians stay home. It's a significant problem. Now that I'm in the doctor business, I've got to buy insurance or self-insure it. And some of these cases are just wild. You know, they get venued in the Bronx and it's like the lottery, number one. Number two, there are lots of debates, and you could find evidence on both sides as to how much it will impact. Some say very little, others will say significantly. I can tell you from all the doctors that I know, the quote unnecessary testing that's done. You know, kid falls off a swing, bumps his head, comes into the emergency room. You can better believe we're going to do a CAT scan because I don't want you coming back later on suing me. We've got to get to the point where we allow physicians to use their medical judgment without having to worry about being sued. Yes?
Is there any hope in your mind that our population is going to be able to deal with the duck problem?
I think the issue is twofold. One is we've got to do something about, you know, put yourself in the position of being a doctor, right? You're in the emergency room and somebody comes in. You're going to do your best medicine, and you know darn well that you've done everything that you should have based upon your training. In the back of your mind, you're thinking, my whole career, my employment, my family's future is hinging on whether or not I'm going to get sued. So what are you going to do? Everything possible not to be sued. All right, number one. Number two, the duck problem would have been solved if the lady knew that she was going to be charged for the CAT scan and the lab results. If there's a connection. So I think those two things, and they eventually have to be. You know, as an example, you cannot charge smokers more money for health insurance. You can give people discounts who don't smoke, but you can't charge them more money. You can't differentiate. But on the other hand, if I've got speeding tickets, I'm going to pay more money. If I have more accidents, I'm going to pay more money for the privilege to drive. We've got to connect it. Question? Yes?
You say you were shocked by how little money doctors are getting paid. Can you give us some examples, please?
Sure. A brand new primary care physician, okay, brand new, just graduated, somebody coming out of Columbia, right? Probably with benefits, we could hire them tomorrow for probably, and I'll be generous, $140,000. Right? And they won't make much more than that over their career. Now put that in relative terms. And you want them to live in Westchester. All right? And they got loans. You know, and that's some of the good ones. I've got experienced doctors that'd be happy to make that much money. Now we've got some that make more than that, but they've been around a while. But when I came here from Maryland, I was really surprised when I realized how much people were making. They make more money in Maryland than do here. It's just so expensive here. And there's so many, part of the reason we have so many doctors. Yes?
Along the same lines, you say that the physicians are going down in pay, and $2.3 trillion out of our economy is huge. What's the breakdown of the cost expense of that 2.3 trillion. How much for doctors, how much for nurses, how much for new equipment, how much, where is the increase, this 19%? I know in our company, our costs have gone up 11% for just in 1 year. Where is the increase in healthcare?
The bulk of the costs, and again, it depends on which of those you want to look at. In Medicaid, it's in nursing home care. In Medicare, it's the end of life issues. You know, the bulk of the money is spent in the last 6 months of life. When you divide it between doctors and hospitals, the bulk of the money is in the hospital side. For what it, you know, that's the most expensive piece of this. In terms of, and I don't have the direct percentage of that, but it's available. I'm going to say it's, you know, the physician component is maybe 20%, but I'm not sure. Do you agree with that, Jim?
Yeah, 8%.
Yeah.
Just a follow-up on that. There are 155 million jobs in the United States, and if healthcare is 19% of the entire GDP, then you've got roughly 30 million people involved in healthcare. Now, is that an accurate number? And if so, how many are doctors, how many are nurses, how many are employees, and how much is machinery and services?
I'd be guessing, and I don't know, but I think that it's a safe assumption to take that 17% of the total population, and without doing some research, I'm not sure you know, where you draw the line in healthcare, whether it's doctors, nurses, which are the obvious ones, but you've also got nursing homes, you've got pharmaceuticals, you've got device manufacturers. I mean, it's a big, big business. So I'm not sure without doing more research. Yes?
The presentation sort of begged the issue of this sort of 5 to 1 or whatever, why is it so expensive here in New York versus Connecticut? Why, if I have a procedure, you know,
It's less expensive here.
And why is that?
Because of the of what we are paid by managed care companies. So again, I go back for the example that I gave about you had a let's say you had a hip replacement, and in 1996, New York State, prior to that, was regulated. It was a single payer regulated system. It came out from that regulation and negotiated individually with each of these managed care companies, but the negotiation didn't start at the market rate. It started at a much lower rate. Connecticut and New Jersey were not. So hospitals have negotiated over time with these insurance companies trying to get up to a market rate. We peg everything in the country as to the cost of Medicare. So everything is a percentage of Medicare, because basically that's a one standard across the country that you can, there are slight variations. The metropolitan areas get paid a little bit more, but it's you know, and we're paid about 105% of Medicare here by the commercial insurers. Connecticut and New Jersey, it's in the 120s, 125. In some of the Midwest countries or counties, in the states, you'll see 130, 140%. Those of you who live in other or have visited other parts of the country, compare the hospitals in those parts to the hospitals here. Much, much more modern. The investment in plant and equipment, significantly more. Yes?
I just wanted to support one point that you made, and we have a tendency in this capitalistic nation to think that if we pay more money for something, it has to be better. That is not the case in healthcare in the United States. CMS did a study in the early part of this decade that demonstrated that the higher per capita Medicare costs did not result in better quality. And so that's a conception that the American public needs to embrace and realize that it doesn't mean that if you pay more for it, it's necessarily better in healthcare. And the second point that I want to make, I'm a registered nurse, I'm a nurse practitioner, is that nationally, we must look at the data and move from our traditional 100-year-old concept of diagnose and cure, because that is no longer the mainstay of healthcare in this nation. From diagnose and cure to prevent and manage. 100 years ago, yes, 100 years ago, there was no insulin, there were no antibiotics. The prevention pretty much was non-existent. You either got better or you died. 100 years later, we're living longer than any people in the history of mankind. We need to learn how to manage healthcare, and that requires individual responsibility. And on the part of the healthcare provider, it requires education of the population. So that when a patient goes to the hospital and they get sent home, there's no payment for what happens between when they leave your hospital and they get to their house. Nothing. So then they have to go back to the hospital, and the burden falls back on a healthcare system that is unprepared to deal with it. So we really, the nation, all of us, not just President Obama, not just the Senate, not just the physicians, not just the nurses, if we want this to work as a nation, then every individual in this nation, or the thought leaders in this nation, need to embrace the reality that we need to prevent problems, and then when they happen, because we're human and they will, manage them effectively. Not fee for service, not as many people as you can see, that's how you get paid, managing care. That has to happen.
I think that's the model shift that will take place. And there's an excellent article that was, I think it was a year ago, in the New Yorker called The Cost Conundrum, which looked at a couple different disease diagnoses in a couple different cities and saw the differences in what was done, just based on practice. We've got to not only do we have to remedy that, but we also have to remedy how we deliver the care. Yes, Fiji.
Ed, if you had a son or daughter now, college graduate age, would you advise them to look into medicine as a career or not? Absolutely. Why not?
All right, absolutely. First, for a couple of reasons. One, it's a significant part of the economy, number one. It's also a growing part of the economy. It's where the jobs are, number two. But whether you're a nurse or a doctor, it is a tremendous gift to be able to reach out, help, touch, and heal people. I can't imagine anything better with your life's work than to be able to do that, to have it be fulfilling. It's still not your father's medicine, but maybe that's good. But the kids today coming out never experienced that. They're looking at it very differently. And the model that we're providing, where you're seeing them now employed, gives them a job that's normal. Now, their parents, on the other hand, if you didn't ask me whether I'd say the parents would you encourage, because it's a very expensive bill to train all these physicians and nurses, but I wouldn't hesitate at all. I think it's, again, I always say that it's just, I can't imagine being given a gift any better than to be able to heal somebody. Yes?
One more question. I think it's important to remember that, like your restaurant example, 100 years ago, you got a hot dog for $1. Now, the equivalent, now your menu has increased 6 servings or whatever, steaks and everything. You're still trying to get it for $1 more. We've been sort of concentrating on us older folks, but look at the other end. Look at all the premature babies that are born and kept alive that years ago would not be here. Absolutely. And that all costs money. Bone marrow transplants, kidney transplants,
all the pharmacological
advances have been fabulous, but it's expensive. Well, thank you very much. Thank you, sir.